immune complexes. We've always been discussing immune complexes, right? From lupus, from Sjogren's syndrome, from systemic sclerosis. So once the immune complexes deposits in your small or medium artery or even veins, then those are your small vessel vasculitis. Sometimes, ANCA-associated, which are the most common small vessel vasculitis, are also affecting now your small to medium vessels. Okay? For medium, the adult form is your polyarteritis nodosa. It it can involve now your medium to large vessel. But for your large vessel vasculitis, which involves now your aorta and its tributaries or the branches, sorry. So the branches are your coronary, subclavian, carotids. Okay? So that is your large vessel vasculitis. But we also have other vasculitis that affects uh, various vessels. It can be ranging from small, medium, and large. All right? So we have that. We will discuss that later on. Okay. So again, it is heterogeneous and overlapping. So the symptoms can be similar from each other, but they have distinct characteristic in which you're going to memorize later on. Okay, so let's talk about the pathophysiology. So first, I mentioned this earlier, it can be from immune complex deposition. Second, it can be from your anti-neutrophil cytoplasmic antibodies or your ANCA, and probably T lymphocyte deposition. Okay, so for immune complexes, again, um, it can be from the combination of your antigen antibody and your complement. Okay, because of the activation of your complement system. This can be through infectious processes or probably autoimmune illnesses. But for ANCA-associated vasculitis, these are from the autoantibodies present in your body. Okay, or the present in the system of the patient. It can be either C-ANCA and P-ANCA. I'm focusing uh, on these two terms, but the latest terms for this one are your proteinase 3 and MPO, your PR3 and MPO. But before, when I was still a student, it is known as ANCA. That's why it is C-ANCA and P-ANCA. Okay, you might not be able to meet these words anymore, but if you are pertaining to cytoplasmic ANCA, these are your proteinase 3, okay, or PR3. And then for P-ANCA, located on your perinuclear membrane, it's called your myeloperoxidase. So it's MPO. But sometimes for old journals, sometimes when you do your research, you can read C-ANCA and P-ANCA. Just the same, that's the same as your PR3 and MPO. But you have to know that PR3 is your C-ANCA and MPO is your P-ANCA. Now, how about T lymphocytes? So this is related to the activation of your inflammatory cells as mentioned, as indicated in the screen because of inflammation. Now, what are the symptoms? So most of the vasculitis, are you familiar with palpable purpura? Anyone? Are you all familiar? Or have you heard of palpable purpura? We make sure that you know what palpable purpura is. When you say palpable purpura, what type of lesion is this? Anyone? Anyone? Have you heard of palpable purpura?
Yes, Budo.
Okay, so the description of you have to answer me because I cannot see you on the screen. I'm just looking at my slides. So I'm not sure if you're listening or not, but it doesn't really matter. But just give me a signal so I can move on. Okay, So palpable purpura is actually described as your macules, your papules. They are raised lesions. It is sized as macule or papule, but sometimes they coalesce to represent a bigger lesion. It's palpable, so because it's raised, and sometimes they are. Most of the time, it's non-blanching. When you say non-blanching, once you press the lesion, it doesn't change its color. It's still red. All right, so that's your palpable purpura. Remember, because this palpable purpura signifies an involvement of your vessels. Okay? Sometimes they can present as pulmonary infiltrates because of inflammation in your lungs, microscopic hematuria because of involvement of your kidneys. It can be from chronic inflammatory sinusitis because some of the vasculitides can present as upper respiratory tract. So it can be a polyp, it can be a sinusitis, or probably deformities in the nose or upper respiratory tract. Mononeuritis multiplex, I think I've discussed this already. We've differentiated what is a mononeuritis multiplex over the difference between mononeuritis and polyneuropathy, right? So we also have unexplained ischemic events. Once a young patient, less than 50 years old, once they experience myocardial infarction, cerebrovascular accidents such as probably a cranial cerebral ischemia, it doesn't really happen in younger individuals. So you have to think of, you have to work up these patients and consider vasculitis or even autoimmune illnesses for that matter. You have your glomerulonephritis. Again, if this happens in a younger individual in the absence of chronic kidney disease, then you consider vasculitis. Not only vasculitis, also autoimmune illnesses. Okay? So if there is an evidence of a systemic or multi-system disease, always consider vasculitis if there is palpable purpura. And then, once you are presented with these conditions, you rule out these conditions also. So because these are uh, the the other causes of your palpable purpura or multi-system diseases. Once you rule this out, then you you follow this algorithm, you check the clinical findings, you do a laboratory workup if you want to establish a diagnosis of the palpable purpura and do a biopsy or probably angiogram for patients who had ischemic events, especially in the young population. So once you establish the diagnosis, um, then probably manage the patient. So for this algorithm, we will discuss this one by one. So as soon as we discuss each of the diseases, we'll follow this algorithm. Okay? So going back, as you can see, this is the classification of your vasculitis. All of these common vasculitis will be discussed one by one. So I made it into a tabular form. Now, let's start in the small vessel vasculitis. So again, we have two major classification of small vessels. So this affects now your small to medium, especially your ANCA-associated vasculitis. These are the most common, and also immune complex mediated. For ANCA, there is presence of your PR3 and MPO. For immune complex, there is deposition of your um, of your immune complexes. Now, let's focus first on these three. Okay? So first, your ANCA-associated vasculitis, your AAV, let's discuss GPA or granulomatosis with polyangiitis, GPA. This term, Wegener's granulomatosis was used before when I was still a student, but at around 2010, there has been reshuffle or new nomenclature for vasculitis. I just wrote it here because most of the time, once you search for a literature, Wegener's granulomatosis will come out. So Wegener's granulomatosis is popularly known now as your granulomatosis with polyangiitis. Your GPA, classification of your ANCA-associated vasculitis involving now your small vessels, is relatively common. It affects at least 3 in 100,000 individual. The male to female ratio is 1 to 1. So it's equivocal. It 15% of the time it can occur at any age. And the mean onset would be approximately 40 years of age. So if a if younger than, or if it involves now your younger individual, your pediatrics, 15% of the time. Um, but they can be asymptomatic in 30%. Okay? So the pathophysiology is necrotizing vasculitis, meaning to say there is granuloma formation. That means there is aberrant cell-mediated immune response. So because of the presence of your autoantibody, the presence of trigger, the granuloma formation is triggered through your inflammatory uh, cell activation. Now, you diagnose by biopsy, you would see vasculitis and granuloma. When you say vasculitis, there is an inflammation of the cell. The sorry, the vessel. So once you see, what do you see in inflammation of the vessels? Definitely, it's infiltration of your neutrophils, right? So you call that leukocytoclastic inflammation. All of the biopsy results of this small uh, vessel ANCA-associated vasculitis is the presence of leukocytoclastic infiltration in your biopsy. So 90% of the time, GPA has a presence of P3 antibody. What is P3 again? That is your CNCA, right? So CNCA. But MPO can be positive. No, and but 20% of the time, ANCA can be negative. Before, when we were students, it's very important to mention the autoantibody actually. So once you know that there is CANCA positivity, or that's your P3 antibody, you are now dealing with GPA. But in the later part, in the recent studies, actually your ANCA findings is insignificant now. Why? Because P3 can be positive in 90%, but also MPO can be found in granulomatosis. But 20% of the time, it is negative. So what is the clinical implication? You have to look into the clinical profile, the symptoms of the patient, which we are now going to discuss. So right now, if you are going to diagnose with GPA or granulomatosis with polyangiitis, it's very important to mention if they are P3 positive, MPO positive, or seronegative. I hope you get that correctly. Okay? So in your diagnosis, it's very important to mention their positivity when it comes to these autoantibodies. Now, what's important in GPA is that, look, it has 85 to 90% involvement of your lungs, especially your upper respiratory tract. Okay? So what are the symptoms or signs for upper respiratory tract? There is nasal perforation, you have saddle nose deformity. Later, I'll show you a picture. Sometimes there is sinus pain that is chronic. Sometimes it can affect the ears owing to the connection of your larynx to your ears, your eustachian tube. No, there can be chronic purulent discharges over this drainage system. It can be uh, problem in your trachea. No, they present with cough, hemoptysis, dyspnea, chest discomfort, and fibrosis or even atelectasis owing to the involvement of your lower lungs. All right. So 52% of the time there is involvement in the form of conjunctivitis, episcleritis. Note that you can see this in all or most of the diseases that we've discussed. Okay, skin involvement is just 46%. What is the clinical implication? Not all patients would present with palpable purpura. Remember that. What you have to look at is the chronic involvement of your upper respiratory tract, your ears, and your nose. And renal, 70% of the time, it can be rapidly progressive glomerulonephritis. So sometimes they have focal segmental glomerulonephritis. What does this tell you? It can be nephrotic, it can be nephritic syndrome. Okay? So this occurs in a young individual. And you do not base your diagnosis of GPA or all vasculitis with skin lesions. Okay? So, if you have to remember one manifestation for GPA, it's the upper respiratory tract uh, uh, involvement. Okay? And then there is an incidence of venous thrombosis, DVT, pulmonary embolism, owing to the fact that they have a hypercoagulable state. Okay? So, in this table, lifted from your textbook, again, look, the most commonly involved organ in GPA are found in your upper respiratory tract, your nose, your throat, and ears. It's 92%. And lungs is just 85% and down the line. Okay? Just review this. What you have to remember is your ear, nose. Your kidney is just 77%, but it can still be affected, either nephrotic or nephritic. Okay, always remember that. You have sinusitis, nasal disease, otitis media, hearing loss, subglottic stenosis, ear pain, and oral lesions. Okay, what are the laboratory findings? Again, it's very non-specific. You can have elevated ESR or CRP. You have leukocytosis, mild hypergamma-globulinemia. RF can be positive at times, thrombocytosis owing to the fact that there is an inflammation. Again, 90% P3 antibodies, 20% of the time, it is negative. So, actually, getting a negative autoantibody will not rule out this condition unless they've been biopsied, they have palpable purpura, and other symptoms. So, this constellation of symptoms make us diagnose patients with GPA. So again, I've mentioned necrotizing granulomatous vasculitis, but uh, the highest diagnostic yield will be your pulmonary tissue. Sometimes they do biopsy of your sinus, in your upper respiratory tract mucosa. We refer this to ENT. And then sometimes most patients can be seen by ENT for the long time, and then if it's untreated and then it becomes chronic, they refer this to rheumatology. If renal is involved, it should be post-immune glomerulonephritis. Now, this is your saddle deformity. These are your granuloma formation or ulceration of the skin. These are your palpable purpura. Okay? So, any question with GPA? This is just an additional information. We use this to classify um, GPA, but not necessarily used to diagnose. Okay? So any question? Can we move on to the next disease? Any clarification?
No po.
Okay. So the treatment is just like the treatment in all other autoimmune illnesses. If you have involvement of your target organ, your vital organ, especially your lungs, your kidney, we do induction phases of your cyclophosphamide. I think this is not new to you because we've been discussing this to all other autoimmune illnesses. And then, if rituximab, you use that if there is no response to the initial maintenance medication. Glucocorticoids, the main state of treatment, but you need to use steroid sparing immunosuppressants. Okay? So for your maintenance, you can use methotrexate, azathioprine, mycophenolate mofetil, depending on the prominent symptom. Okay? So remember that treatment because the treatment is just the same as the treatment here in your second small vessel vasculitis of the ANCA-associated uh, type, which is your microscopic polyangiitis. This is MPA. Note that there is no previous name. Why? Because this is a relatively newer vasculitis. This is actually under your GPA before, so it was interchangeably used, but not late but recently it was it in the nomenclature it was thought that it is a separate entity from GPA. Why? Because this is common in male and usually affects now yung elder population. Okay, the mean age is around 57. Remember that in GPA it involves both male and female in the younger population. There's no established classification criteria, again, because it is a relatively newer vasculitis. So we diagnose based on histology once we do biopsy, your biopsy and also clinical. So what's the difference of MPA and GPA? So for MPA, it also involves your capillaries and venules. All right? There is an IG deposition or immunoglobulin deposition to a lower extent. So if you do biopsies, just the same as your GPA, which shows on your vasculitis and your granuloma formation. But it is highly associated with MPO. Now, again, 75% of the time, there could be a positive ANCA, but predominantly MPO, but it does not necessarily mean that you only see MPO. You can also see seronegative antibodies. Okay, so what I want you to focus on are the manifestations. So what is more common in MPA? It's the lower respiratory tract. A while ago, for GPA, it's the upper respiratory tract. So the presentation is usually hemoptysis or alveolar hemorrhage. I think we've discussed alveolar hemorrhage in lupus. It's one of the detrimental um, symptoms or signs in the pulmonary of SLE. But here, it's also common in MPA. They can have glomerulonephritis. In GPA, it's 77%. Here, it's 79%. All right? So, they also present with non-constitutional inflammatory symptoms. Neurologic mononeuritis multiplex is common. What you have to remember here in MPA is that sometimes it's similar with GPA, but it affects more the lower respiratory tract. Same laboratory findings, and then the relapse rate in MPA is higher than in GPA. Okay, same treatment. You also have similar maculopapular rashes or vasculitis. Okay, so are we good with MPA? You can easily differentiate MPA and GPA.
Opo, opo daw.
Okay, so let's move on to EGPA. EGPA is the third installment for ANCA-associated vasculitis. Okay, it's called eosinophilic granulomatosis with polyangiitis. It was otherwise known as Church-Strauss syndrome. Okay, but it is widely known as EGPA in right now. Okay, so for the sake of literature review, it's called as church straws, but we use EGPA. And it's very easy to differentiate from MPA and GPA. Why? Because it's eosinophils that infiltrates your tissues, right? So, why is it eosinophils? What's the importance of eosinophils in the body? So, remember that this is characterized by asthma, peripheral and tissue eosinophilia, extravascular granuloma formation, and multiple organ vasculitis. So, it is related to hypersensitivity. And you know that in hypersensitivity, it's the eosinophils that is elevated. But it's relatively less common. No, it affects 1 to 3 individuals in a million population. It affects any age except your infants. Why? because at this age, they did not develop the hypersensitivity reaction yet. Is that correct? Did you know that infants do not get hypersensitivity because they don't have the antibodies yet? So the mean onset of age is usually 48, and females are more commonly affected than males. Okay? So for EGPA, same as same involvement, small and medium sized muscular arteries, you appreciate eosinophilic infiltration. It is also present in the tissues, in the vessel walls. It occurs in any organ, your lungs, skin, cardiovascular, kidney, in your peripheral nervous system, and your GIT. As you can see in GPA and MPA. But the thing is, it is the eosinophils that are predominant. All right? So what you have to remember is that there is commonly involvement of your lungs. Okay, lungs because of asthma. And then mononeuritis multiplex is the most common presentation. What's mononeuritis multiplex again? To review, it involves one extremity or one focal area that causes now numbness, paresthesia, tingling sensation, electric sensation, pin and needles, whatever you call it. That's mononeuritis. It's different from peripheral neuropathy, which involves now symmetric extremity. Okay, either the upper or the lower. All right. Cardiovascular involvement is common. Just like systemic sclerosis, once you have involvement of the heart, then it makes um, it makes the prognosis very poor. No, by studies, within 5 years, the patient is going to succumb to death. That's why we require 2D echo to all patients that are newly diagnosed with EGPA. Okay? ANCA can be positive, but 48% of the time it can be MPO. But it's not necessarily required because what you have to look at is the biopsy findings. And you would see at least more than 10 per high power field of eosinophils in the tissue. That's 80% of the time. Again, the laboratory tests are non-specific, same as your inflammatory markers. So here's classification criteria for reading. They use to classify EGPA. But again, once you have mononeuritis multiplex, you have asthma, you have cutaneous lesions, palpable purpura, then consider EGPA. Question?
None po.
So here are the types of um, palpable purpura in the EGPA, and then this is an image of the biopsy. You would see eosinophilic infiltrates, perivascular, all level, all layers of your um, vessel. So how do you treat patients with EGPA? Then you can start with glucocorticoids, then you can combine it with cyclophosphamide, methotrexate, azathioprine, depending on the presence of your internal organ damage or involvement. So same as your GEPA regimen. So here are the other biologics that you can use if it's relapsing, if it's non-responsive to your immunosuppressants. Okay, so I think I mentioned this. If there's myocardial involvement, it increases now your mortality, and the prognosis becomes poorer, which gives you 5 year survival of 25%, very low. But with treatment, and if there's no involvement of your cardiovascular system, then the survival rate is actually high. It's around 72%. Okay? So, we've discussed the ANCA-associated vasculitis. I hope that you know how to differentiate now your GPA, MPA, and your EGPA. Because we're moving on to discuss the immune complex mediated vasculitis still under your small vessel vasculitis. Now, first is that we have your IgA vasculitis. It's relatively common. It's otherwise known as your Henoch-Schönlein purpura. Be- Until now, they are still using HSP or Henoch-Schönlein purpura. I think you might have heard of this, but it's better to call it IgA vasculitis, owing to the fact that this vasculitis or the immune complex deposition involves now IgA or immunoglobulin A. Okay? It presents as palpable purpura. Usually, it does not extend beyond the buttocks or abdomen. So it only affects on your buttocks and lower extremities. But I've seen patients who also has lesions on the abdomen and in upper extremity. Okay, usually seen in it is bimodal. You can see it in younger population. You can see it in older population. So if you have a patient in the younger stage, then probably um, they have corresponding hypersensitivity reaction because it is triggered seasonal, especially in the spring because of pollen, right? And then without biopsy, you can diagnose IgA vasculitis using clinical parameters. So remember that there is actually triad for HSP. Remember, it's not on the slide, so you have to take note of this. They present with arthralgia or arthritis, abdominal pain, and palpable purpura. Again, the triad for IgA vasculitis, that's how you clinically diagnose patients with this condition. You have arthralgia or arthritis, abdominal pain, or your um, palpable purpura. Okay? Skin biopsy is helpful just to um, confirm your diagnosis. It will show again leukocytoclastic vasculitis with IgA deposition. Okay? Renal biopsy can be done if you have sudden decrease of your renal function because again, if your triad for IgA vasculitis is arthralgia, arthritis, abdominal pain, and lower extremity. Um, lower extremity. Um, palpable purpura. Those three. If you add decreasing sensorium and decreasing renal function, you call that IgA nephropathy pentad. Is that clear? You have IgA triad for IgA vasculitis, but once it becomes worsened, it becomes your IgA nephropathy. That's pentad. You include decreasing um, renal function and decreasing sensorium. But it's not part of our discussion because that's part of what do you call this? That's part of your discussion in nephrology. All right. So remember that it can involve or it can develop to glomerulonephritis or IgA nephropathy 10 to 50% of the time. So biopsy is very important to check for IgA deposition. Now patients would present with palpable purpura, arthralgia, and abdominal pain that is colicky abdominal pain, making it now your triad, and then other symptoms. Myocardial involvement is rare in children. So it can occur in children, but myocardial involvement is rare. It only occurs in adults. Okay? The thing here is that complement system is normal. Always remember this. C3, C4 is normal in IgA vasculitis. You have to note this or remember this because it's important in the next condition. Okay, the treatment is usually glucocorticoids or supportive. If there's abdominal pain, you give PPI. If there's rash and arthritis, you give glucocorticoid. But it will just resolve on its own. So you just need to monitor the patient to rule out development to nephropathy. All right? Because once they develop nephropathy, it will be a sign of poor prognosis. Okay? So there. Excellent. It will resolve on its own. Once the triggers resolve, just like infection, virus or bacteria, or even triggers from your pollens from spring season, then the 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 prognosis will become excellent. Mortality is rare unless you have end stage renal disease. All right. So this is a photo of my patients. So this is the type of your palpable purpura. Look at this. It also involves your abdomen, but in the book it says rarely extends beyond the buttocks. But biopsy has been done in this patient, showing you now IgA deposition. Okay, so you have to request skin biopsy if you are not sure of the diagnosis. Why? Because I have to skip this and let's go back later. Why? Because here, if you go back to this table, area of the table, I did not discuss HUVS. It's your hypocomplementemic urticarial vasculitis syndrome. It's just similar as your EGPA, okay? But it does not present with IgA deposition. It's just because of hypersensitivity. And in here, complement system is actually elevated or decreased. All right? Remember that in IgA vasculitis, it is normal. Is that clear? So we can go back to cryoglobulinic vasculitis. Okay? This is because of your cryoglobulins. So what are cryoglobulins? These are cold precipitable monoclonal or polyclonal immunoglobulins that is released from hepatitis C infection. The incidence is not yet established, but once you have hepatitis C, these viral elements will produce your cryoglobulins, which will now deposit in your vessels. Okay, that will cause now aberrant immune response, causing now several diseases, multiple myeloma, lymphoproliferative disorders, connective tissue diseases such as your vasculitis, infection, and even liver diseases. Okay, so it's very important to do a biopsy showing now fibrinoid necrosis. Always remember that fibrinoid necrosis, endothelial hyperplasia, and hemorrhage. Okay, so again, same as other conditions, they present with palpable purpura, arthralgia and weakness, they have neuropathy, MPGN, you have inflammatory bowel diseases, and infrequent involvement of your uh, myocardium. Now, look at this clinical manifestation. It's just generally similar with other um, similar vasculitides. But but what will sorry, I think it's noisy. Can you hear me?
Yes po, Doc.
Okay, I'll just cover my mouth because I think construction is going on. All right. So for cryoglobulinic vasculitis, there is presence of cryoglobulins and inflammatory biopsy would show fibrinoid necrosis. So this is very important because relatively similar with other vasculitis. But the treatment is you have to look at hepatitis C infection. Once you treat this patient with hepatitis C, then there will be an improvement of the symptoms. But if you need also to give an adjunct in the form of glucocorticoid. Plasmapheresis has been studied to effectively treat the hepatitis C infection. So it's just cleansing or cleansing the blood with cryoglobulins. Rituximab can be used for refractory disease. Okay? Mortality is uncommon, but poor prognosticating sign would be involvement of your kidneys. So these are the the palpable purpura in your cryoglobulinemic vasculitis, but it can also present as ulceration and ischemia. Okay? And then biopsy is very important to identify cryoglobulin deposits. They are like giant cells in your cells. Okay? So, on this part, biopsy is very important. So here's the classification criteria for IgA vasculitis and your cryoglobulinic vasculitis, which are immune complex deposition vasculitis in your small vessels. Questions? Because we've just discussed all the small vessel vasculitis. So we have ANCA-associated, we have immune complex mediated. Question?
None po, Doc.
Okay, so let's move on to discussing medium vessel vasculitis. So most of the time, these are the vessels that are located in your internal organs or any organs. It's relatively bigger organs, right? You have your renal, your mesentery, and so on. Now, what we are going to discuss is only this, we will just focus, but I'll try to discuss Kawasaki disease. Why? Kawasaki disease is commonly seen in pediatric population. It rarely occurs in the adult. Once adult presents with KD, it's already a complication. So they have been affected with Kawasaki disease in their younger years and then just have the adverse complications once they reach adulthood. Okay? So let's focus on polyarteritis nodosa. Okay, PAN. It's still the same name. It wasn't changed, but it's relatively uncommon. Again, this is necrotizing vasculitis involving your small or medium-sized muscular arteries, especially in your visceral arteries and renal arteries, your mesentery, and the like. It does not involve pulmonary arteries. So, you do not have any symptoms from your lungs as compared to uh, the vasculitis like GPA, MPA, and EGPA, right? So once they ask you in the board exams, there's no involvement of the lungs, but it has renal problem, then polyarteritis nodosa is the answer. Okay, it shows as granuloma, eosinophilia, and allergic diathesis. Same as what you see in small vessel vasculitis. So be careful in test taking techniques or strategies. They would ask you this because it does not affect your lungs. Okay? So the pathophysiology would be the most commonly affected vessels are the bifurcation, the branchings of your vessels. Now, once you see thrombosis on that area, infarction, or even hemorrhage, there is involved aneurysm. Okay, so it is related to hepatitis B infection. So that's your PAN. For hepatitis C, it's your cryoglobulinemic vasculitis. That's why if you are presented with palpable purpura, you always request for hepatitis profile. Okay? So the most common, as you can see here, is still musculoskeletal and renal. And you do not see pulmonary involvement. All right? So no serologic test required, but relatively it will show you non-specific inflammation. You need to request for hepatitis B and C screening, biopsy. Biopsy is important. You would see fibrinoid necrosis. For imaging, angiography, you would see aneurysms in the bifurcation of your renal artery, mesenteric artery, or any visceral artery for that matter. If you want to do biopsy, it should be on the nodules, in the painful testes, or in a nerve or muscle that is involved with ulceration. That will show you a highest lead, not the palpable purpura. Is that clear? So here's your classification criteria. Just read on this one. So the treatment would still be same as your previous vasculitis. You give glucocorticoids, cyclophosphamide, or other form of immunosuppression. You treat your hepatitis. Plasma exchange is again treatment for hepatitis B infection. You treat hypertension if there is an involvement of your renal artery. Poor if it's left untreated, 5-year survival rate is at around 10 to 20%. That's very low. And if there's GI complication, it would present as GI infarction or perforation. So what's the pain again? If you have mesenteric ischemia, it is abdominal pain out of the proportion. Always remember that when you say pain out of the proportion, you have abdominal or you have colicky abdominal pain, severe. But once you do palpation, you will not elicit tenderness. So that's pain out of the proportion. Okay? Note that in polyarteritis nodosa, it is relapsing in 10 to 20%. Is that clear? Now let's discuss Kawasaki disease. As I mentioned, this is common in pediatric population. They present as acute febrile episode. Okay, presenting as your strawberry tongue. They would ask this in the board exam, but in pediatrics, you have erythematous uh, facial, and even your soles and palms are erythematous. Okay, so this is the classification criteria. The not detrimental, the most common symptom or adverse complication in Kawasaki disease is your pericarditis. Okay, so once they have this, once they turn adult, they would have cardiac or heart failure once they become adult. Okay? It is self-limited, but again, if it left untreated, it can cause cardiac adverse complication. So you give high dose IVIG and aspirin. Imagine 100 mk day. How much of an aspirin would you give for these patients? And then tapered by 3 to 5 mk day. Okay, so why would you give aspirin? Owing to the fact that aspirin can be an anti-inflammatory, it's an NSAID, and it has a cardioprotection. Question, I will not include this in the exam because Kawasaki disease is part of your pediatric cardiology. At least you know that Kawasaki disease is actually a vasculitis. Okay? So we just discussed the medium vessels. It's only polyarteritis nodosa that is clinically significant in the adult population. Now, let's move on to discuss your large vessel vasculitis. Again, this involves now your aorta and its branches. What are the branches of your aorta? You have your coronary, you have your subclavian, you have your carotids. Clear? So let's start with giant cell arteritis. It is otherwise known as your temporal arteritis. Why? Because it's the temporal artery is the one that is involved in this inflammation. And it is closely related to your polymyalgia rheumatica. 40 to 50% of polymyalgia rheumatica has GCA. And then 10 to 20% of polymyalgia rheumatica, they will develop to GCA. It's relatively uncommon among Asians, but this is common among Hispanics, among white population. Okay, polymyalgia rheumatica is an inflammatory condition of the neck muscles that causes now chronic inflammation. So it causes now pain and weakness. All right, but for temporal arteritis or your giant cell arteritis, it involves inflammation of your temporal artery. It is exclusive in the adult population. You do not get to see patients, young population with GCA. So this is exclusive in 50% of the time. It is common in your Scandinavian and US group or even Hispanics. Okay? You do not see that in Asian population. It's very rare. Owing to the presence of your HLA-DR4. Okay? So pan-arteritis of your temporal artery, meaning to say all layers of your temporal artery is affected, your intima, media, and adventitia. There is mononuclear cell infiltration of your giant cell or your T lymphocyte, your macrophages, and dendritic cells. Okay? That is very different from your leukocytoclastic infiltration in your small vessels. Here, giant cells are present. And these are the lineages of your CD4 cells that can be seen as well. So, the most common symptom is headache. It's associated with tenderness, feeling of thickened scalp, or nodular artery. You feel the patient feels like the temporal artery is pulsating, and maybe due to the compromised vessel or lumen, it can it can cause occlusion. Not only that, it can occlude other vessels, especially the ischemic optic the optic vessels, no, the ones that supplies now your eyes. So they can present a sudden loss of vision after a long-standing headache. Other symptoms could be non-specific, could be your arthritis, arthralgia, polymyalgia rheumatica, scalp pain, jaw claudication, or even stroke, or even larger vessel involvement such as the ones in your subclavian, even aortic aneurysms, and even dissection. But what's important to remember here is that headache and involvement of your temporal artery, pulsating temporal artery, they can present as a stroke or even ischemia in your eye vessels. Okay? So laboratory findings are non-specific. What you have to do is do a biopsy of your temporal artery. There is a guideline, at least a certain amount of your of or a certain what do you call this? How do I say this? A certain portion of your temporal artery should be obtained from for biopsy. I don't recall it, but anyway, I wouldn't ask that question. All right. So as you can see, this is the temporal artery. All the layers are involved. Okay, there is infiltration of giant cells over your media, your intima, your media, and your adventitia. Okay, so as a tributary or as a branch of your temporal artery, of your branch of your aorta, your carotids, your subclavian, it can affect other vessels, surrounding vessels. So this can also cause occlusion leading to ischemic event or cerebrovascular accident. So again, same the management are actually glucocorticoids and biologics. Okay? Tocilizumab among all others is the uh, best studied medication for this. So remember that tocilizumab has been used in COVID-19, right? It's also used in rheumatoid arthritis and in giant cell arteritis. So the indicator, once you saw the biopsy of a giant cell infiltration in your artery and you already diagnosed a patient with GCA and then started patient on medication, what you have to monitor is just your ESR and CRP. That would suffice to monitor inflammatory activity. Okay? Just ESR and CRP because it will be different from other larger vessel vasculitis. So the prognosis is usually it's detrimental if there is cardiovascular accident or cerebrovascular accident. So when you say CVA, it's cerebrovascular, MI is your cardiovascular ischemia. Okay, if you have aortic aneurysms, then 18 times risk of developing GCA or 18 times risk of mortality from GCA. Clear with GCA? Because we're going to discuss Takayasu arteritis. What about Takayasu? So Takayasu arteritis is the inflammation and stenosis of medium and large vessel arteries, especially your aortic arc. It's more common than GCA among Asians. It affects young adolescent or young women, especially Asians. Okay? I have a lot of patients, I've seen a lot of patients with Takayasu arteritis. So they have a problem with aorta, with the aortic arc and its branches. What are the branches? Your carotid, your and subclavian. Okay, again, same as your temporal arteritis, it's panarteritis. There is marked intimal proliferation and fibrosis, scarring, vascularization. So what will happen if you have intimal proliferation and scarring? It will decrease the size of the lumen. So there will be stenosis. And so it will disrupt now the blood flow, causing now ischemia or thrombosis. All right, so these are your constitutional symptoms. The most common would be ischemic. This is ischemic optic neuropathy, stroke, or even scalp and tongue infarction. Okay, so once you see patients with ischemia and they are young female, check Takayasu arteritis. What else? Absent pulse, especially your subclavian artery because this is the most commonly affected vessel in Takayasu. But not necessarily just the subclavian. If you have stenotic, sometimes there will be a discrepancy of your blood pressure. So the blood pressure on your right upper extremity is higher and then on your left is lower. So that's a discrepancy and you have to note that it should be at least above 10 millimeter mercury difference. Okay? So if there is stenosed vessel on the specific side of the body, then that you have a higher blood pressure. So in the other side, the contralateral side should be the normal blood pressure. Okay? So again, non-specific elevation of your inflammatory cells. This is actually your classification criteria. Now, let's discuss the different involvement of your aorta and its branches. You call it type 1, type 2A, type 2B, type 3, type 4, type 5. Type 2, type 1 if the involved ones are the branches. Type 2A if there is stenosis of your type of your aorta, its arc, and its branches. If it involves now your aorta, aortic arc, its branches, and and the thoracic aorta, then it's 2B. If only involves now your abdominal aorta, it's 3. But if it only involves your renal, if it involves now your thoracic, sorry, your thoracic and abdominal aorta, it's type 3. And type 4 if it only involves your abdominal aorta. But if it involves several portions, segments of your aorta, its arch, its branches, the thoracic and abdominal, you call it type 5. The most common of this classification would be type 5. Always remember that, type 5. And let's go to the table. This is the involvement of the different vessels. The most commonly affected vessel in Takayasu arteritis would be subclavian. So the symptom would be arm claudication, Raynaud's phenomenon. Do you know what arm claudication is? We've discussed jaw claudication, right? The jaw becomes painful once you chew. And the claudication in the lower extremity is it becomes painful um, when you walk. But for arm claudication, do you know the feeling when someone gets the BP in your hands? That's arm claudication. Okay? So always take note of that. Other vessels are also affected. But 93% of the time it's the subclavian. So if you have involvement of the left subclavian artery, you will not appreciate pulses in that area. Is that clear? So there would be an absent pulse. And then if left subclavian artery is affected, you would get a higher blood pressure on that ipsilateral area and you'll get a relatively lower blood pressure in the contralateral side. Is that clear? I hope I'm getting the message across because it's very important. This is most common. Most likely you will see patients with Takayasu arteritis. Okay? So how do you treat? In GCA, tocilizumab is the mainstay of treatment. But in Takayasu, it did not demonstrate efficacy. We give methotrexate or abatacept, okay? And also glucocorticoids. Now, in GCA, you only measure your CRP. That would suffice to measure inflammatory activity. But in GCA, But in Takayasu, you need to do arteriography. Arteriography or angiogram or arteriogram. Is that clear? And then the definitive management should be surgery. Okay? I think in thoracic cardiovascular surgery, you discussed this in managing your what are the conditions related to aorta. Marfan syndrome, Takayasu, they are similar. Okay? But w- once surgeons would ask if they can undergo surgical intervention, you need to monitor disease activity using inflammatory markers and arteriography. There should be at least lesser active disease before going to surgical intervention, because if you have a highly active disease, it will not there will be a poor healing process. Is that clear?
Yes po.
Now, for prognosis, the overall prognosis is actually good at around 94%. 5-year mortality is relatively lower. But if you already have problems with cardiovascular diseases, you already have a rupture disease, then that will cause you mortality. Okay? Um, there's spontaneous remission, but it can be relapsing. So it's varied. Okay, so we've discussed large vessel vasculitis. You have GCA and Takayasu. I hope you can differentiate the two. Now let's move on to variable. It's called variable because it can affect any other vessel. For single organ disease, I'll just mention this very quick because I don't have a slide for this topic. It's called single organ if there's only ischemia in one vessel. Just like your if you have stroke in a young individual and only involves one vessel, and it's probably caused by a vasculitis, it does not have any other systemic symptom, so you call that single organ disease. Or you can call that, if it occurred in the brain, you call that primary CNS angiitis or primary angiitis of the CNS. Okay, that's single organ disease. Now let's start with Behçet's disease. Behçet's disease is common among Middle Eastern people, the ones who dwell in the Mediterranean or Far East. So what's common among this population? They are in the area of Silk Road. It is discovered in Turkey. Uh, Imagine in out of 250 individual, one is affected with Behçet's disease. It's rare before the late teens and after age 50. So it is common among the adult population. Male to female is equally affected, but if you have male patients, they are more aggressive. And it has poorer outcomes, and it can be relapsing for male patients. Okay, it's common among this population, the ones that are located in the Silk Road, because owing to the fact of the presence of HLA-B51. Okay, at least 50 to 60% of these patients, they have HLA-B51 positivity. But HLA-B51 can be seen in normal population at around 20%. The pathophysiology is still unknown, but again, it can still be genetic, environmental, and susceptibility of the patient. So the presentation is usually aphthous ulcers. When you say aphthous ulcer, it's painful. Oral, they can be acne-like or papulopustular. They can have this seen in your genitourinary. So what do you say, or what's the clinical implication when once you have aphthous ulcers in your mucocutaneous, in your oral mucosa, or even your genitals? You would think of this as herpes simplex virus, right? So you would think of an infectious process because of the presence of the ulceration in your mucous membranes, in the oral area, and in your genital. But for Behçet's disease, it can also involve now your eyes, your MSK, even your neurologic. Okay? It can cause ischemia. That's why it's very important to check other symptoms. That's why you have your classification criteria, which is specified in your textbook. Or oral ulcers should be present in a 12-month period. It should be recurrent, that at least 3 times. And plus 2 out of 4 in these domains. You have recurrent genital ulcers. Usually they are scarring. You have skin lesions other than oral ulceration in the form of folliculitis, nodosum, or papillus pustular, or even acneiform lesions. You have eye lesions also. It's either uveitis, whether that's anterior or posterior uveitis, and or involvement of your vitreous rumor or retinal vasculitis. That's why it's important to refer these patients to ophthalmologists for fundoscopy to check for inflammation of these vessels. And you should do a Pater G test. So what is Pater G test? Later on, I'll show you a photo of Pater G test. It is a non-specific hyperactivity of the skin due to trauma. So you initiate or you induce trauma to the skin, and then for 24 to 48 hours, there should be a formation of a papule or a pustule. And this is how it looks like. You prick, you use the usual needle to prick the volar surface of your forearm, and then observe for 24 to 48 hours. It should develop a pustule or papule. Remember, if you do this to yourself, you wouldn't actually see this. Because it will just resolve on its own. But for Behçet's disease, it will cause papulopustular reaction. So these are your oral ulcerations, and these are your um, genital ulcerations. For female, it can occur in the scrotum or even in the glands or in the prepuce. Okay? So always remember that. So to those who has recurrent ulcerations, better get yourselves check. Okay? So how do you treat this? Usually it's steroids. You use colchicine because colchicine. What's colchicine? We've discussed this in gout. What's colchicine? Colchicine is used in gout, right? But why is it being used in an autoimmune illness? Anyone?
Does it have immunosuppressive agent property? Like
So
immunosuppression.
what's the mechanism of action of what's the mechanism of action? It's actually it inhibits your beta tubules. So the beta tubules are is important in the chemotaxis or recruitment of your neutrophils in an inflammation. So if you have neutrophils, then it will attack the noxious agent, right? So for colchicine, it prevents this. That's why it prevents now the inflammatory response. All right, so that is what it does in gout management. But for for this, it utilizes the same mechanism of action to prevent inflammatory response. That's why colchicine here is used as a maintenance, especially in the formation of your oral and genital ulcers. So if you have genital ulceration, then use colchicine uh, twice a day. But for glucocorticoids, you only use this depending on the involvement of target organ. So eye is a vital organ. So if it's not prevented, your uveitis is not prevented, it's not treated, then it will cause blindness. Azathioprine if there is an involvement of your eyes and your neurologic. involvement or even GI. So if you have this will be your maintenance medication with colchicine if they have oral ulceration, because colchicine will not be able to cover for these symptoms. So you have to give both. The others, your infliximab, adalimumab, these are your biologics that can be given to the patient. Okay? So again, poor prognosis because it is recurrent, especially if male. If there's posterior involvement of your eyes. So actually, once you have patient, you would actually treat them in within a year. But after 2 to 3 years, the symptoms will just come back right away. Okay? So that is what you have to know, so that you will explain to the patient that once you have Behçet's disease, it's actually a recurring condition. Okay? So for those going back to the Middle East, you will see a lot of these patients. Now, let's move on to Kogan. So it's just another variable vessel. What you have to remember is that it involves now your eyes, it involves now your ears. Okay? So that's the additional symptoms. Okay? There is hearing loss, there is blindness. Okay? So the treatment, supportive systemic glucocorticoids or topical glucocorticoids for just the eyes. If it involves now the ears, then you give systemic glucocorticoids. Okay? That's Kogan syndrome. We'll not dwell on this because it's less common. Now, review. We discussed your small vessel. I hope you know your ANCA-associated, immune complex mediated. No questions. No questions?
Yes po, Doc.
So now, we have your medium vessel, which includes now your polyarteritis nodosa or PAN. For large vessel, you have your GCE and TAC. For variable, it's your Behçet's, your Kogan's, and single organ disease. Your single organ disease is similar as your primary angiitis of the CNS. Okay, so for X-ray reading, these are the other vasculated discs that may be related, but it's not discussed in our discussion because it's part of other subspecialties. Just like your good posture syndrome, you will discuss this in nephrology, or you might have discussed it already. So it's a vasculitis involving now your kidneys. Now we have your secondary vasculitis that may be secondary to drugs and infectious. How would you manage this condition? Just withhold the drug or treat the infection. Then you would treat the secondary vasculitis. What's thromboangiitis obliterans? It's Berger's disease. It's highly related to smoking, and it involves ischemia of your lower extremity. That's your Berger's disease. Okay, how about Susak's? It's just like your Kogan syndrome. There is sensory neural hearing loss, retinal, and encephalopathy. So primary angiitis of the CNS, it's a local involvement of your cranial uh, vessels, but there is no systemic symptom. Is that clear? So I think that's the last slide. Any question? You have questions?
None po, Doc.